Let's begin with slide number 1. And slide number 1 is going to be a description or a diagram of the conducting system of the heart. So initially what we're going to do is we're going to talk about specifically some basic physiology, pathophysiology, and then later on in our review we will talk about specifically drug effects. So one of the things that you should be aware of would be that when the heart generates an impulse, the impulse starts with the SA node. That impulse will then progress across the atria, go across the AV node, then go down the two bundle branches to the base of the heart, where it will then progress back up, resulting in contraction. It's very important that the conducting system function properly, and in order to get complete efficiency of the heart in its contractions. Now, many of the drugs that you will prescribe and that we will talk about later on in this PEP review can interrupt the normal activity of the heart and produce arrhythmias. And in fact, if you go to slide 3, what you will see is actually a normal ECG. This is actually a lead 2, and you see the various waves associated with the electrocardiogram. We have initially the P wave, which represents atrial contraction. We have the QRS wave, which is reflective of ventricular contraction, and then we have the T wave, which is reflective of the heart muscle repolarizing and in preparation for the next beat. So the PQRS-T complex, each one of those represents a progression through the cardiac cycle. Now, a couple of other things to be aware of with the EKG or ECG is the PR interval, and the PR interval represents the conduction time from the atria through the AV node. So that's one parameter that a cardiologist would look at and may be indicative that there may be some problems associated with the conduction of the heart. The QT wave is particularly of interest because the QT wave represents a portion of the ECG which, if it becomes prolonged, can produce an arrhythmia, which most of you should be aware of because, for example, the antipsychotic drugs may produce prolonged QT interval and may actually produce what is shown in slide 4, which is torsades. And torsades, notice the very erratic waves here. This is a ventricular tachycardia, and it can be life-threatening, can actually go into ventricular fibrillation. So just a little background there on the electrocardiogram. Now we're going to move pretty quickly to the next slide and just review some basic physiology. And the cardiovascular center is going to, or the cardiovascular system, is going to be controlled a lot by the autonomic nervous system. And so in slide 5, what you see is an outflow of the sympathetic nervous system. And what you see is that the sympathetic nervous system, if you remember, will emanate from first the thoraco or the lumbar portions of the spinal cord. It runs down the intermediolateral cell column of the spinal cord. The preganglionic nerves will then leave the spinal cord, and they will then synapse in most cases in the sympathetic chain. Now the sympathetic chain lies on either side of the spinal cord. Remember that in the ganglia that the transmitter released is acetylcholine, and acetylcholine will then stimulate nicotinic G receptors, the G for ganglionic, of the postganglionic nerves, which will then in the sympathetic nervous system go down and release norepinephrine. And in this case we have innervation to the blood vessels. This can also go to several other organs, the heart, the GI tract, and several others which we'll mention a little bit later. If you go to slide 6, we also have associated with the sympathetic nervous system is the adrenal medullary mechanism. And with the adrenal medullary mechanism, often when you have the sympathetic nervous system that gets activated, what's going to happen is it will stimulate release of catecholamines. And in this slide here, slide 6, we see epinephrine and norepinephrine that is being released from the adrenal medulla. Now it's important to remember that catecholamines come from the adrenal medulla, whereas the adrenal cortex, which is the other portion of the adrenal gland, will release hormones that are acting to regulate salt and mineral and water levels in the body. Now, that was a quick overview. We're going to come back to the autonomic nervous system, but some things that I want you to be aware of as you are looking and preparing for the PEP, and also it's important for you to be aware of these issues when you're practicing, is that when you are looking at patients and you see a condition that's occurring or symptoms that are occurring, it's very important for you to consider, are these psychological symptoms, or are they pathological symptoms, or a combination of the two. With regard to complications associated with pathology, which are going to have an impact on your prescribing and in monitoring patients, we always have to be concerned about liver function, whether the pathology of the liver is going to affect the person's normal physiology, or in some cases whether it will impact the pharmacology and may determine which drug that we're going to choose. The kidneys are important because if there is kidney dysfunction, that can result in the buildup of metabolites and waste products, which can have some psychological or psychiatric implications, such as ammonia. But also any drugs that you give, altered renal function may have an effect in the toxicity of those drugs. We're concerned about any underlying cardiovascular problems. Those cardiovascular problems may impact which drugs we give or what dose that we give. For example, a number of the drugs that you would prescribe may have effects on the heart, and those effects on the hearts could be amplified in a person with, say, for example, an arrhythmia. If a person has a congestive heart failure, for example, we could have underperfusion of organs, the kidneys, the liver, which may impact the effects of your drugs that you're having. And then a lot of drugs may have cardiovascular toxicities, which may be more of a problem when we're dealing with a person that may have underlying comorbidities. Endocrine disruption or endocrine dysfunction would be another concern. Specifically, we'd be concerned about thyroid, and sex hormones would be two that could have some very prominent effects there. So we need to look at all of these underlying problems in order to determine whether they're going to have an impact on what we do. And that leads to the next bullet point, which says implication of drug therapy. We have to be aware of, is it going to affect which drug therapy that we're going to use? That could be the choice of drug. It could also be the dose of drug that we use. And it could also imply that in some instances we may have to increase monitoring of that particular patient if we're going to use a specific drug. The other issue that we always have to be aware of is that as symptoms emerge after starting drug effects or starting drugs, we have to always be careful, because we have to determine, is this progression of the pathological state, or is it a potential emerging side effect of the drug therapy? What we don't want to do is to get into the scenario where that we are giving drugs which are producing side effects, where we give other drugs which then to offset those side effects. So we can very easily move into polypharmacy if we're not careful. One of the things that we do know, going to slide number 8, is that a number of pathological states may actually express psychiatric symptoms. And so again, it's very important that we identify those. As I just alluded to, our treatment should be based on treating the primary disease versus trying to treat side effects and add more drug therapy on. And then an old clinician pointed this out to me, and I believe this wholeheartedly. You do not fit the patient into your practice. Sometimes what happens is that clinicians will try to, when a patient shows up, they may have other things going on, and they will try to treat the patient based upon their expertise and their practice, whereas in many cases you need to think outside your discipline and involve other healthcare professionals in the treatment of the disease. Most disease states we're going to see are going to be multifactorial, and is going to require a number of physicians in treating the disease properly. Things to be aware of, for example, is that if you have some hematological problems, such as an anemia, that person could experience or exhibit symptoms of fatigue, dizziness, tachycardia. At the same time, the dizziness or tachycardia may be perceived as being a symptom of a panic attack or of a fear or anxiety. Fatigue can sometimes be associated with depression and other types of diseases, and so the question becomes, are we seeing a symptom associated with the psychological state, or are we seeing a symptom that is pathological? So again, a simple blood test could give us that information, and we need to be aware of that. Cardiovascular problems, this can be anything from development of atherosclerosis, which can lead to things such as coronary artery disease. It can lead to myocardial infarctions, strokes. A person with arrhythmias, a person with congestive heart failure, a person with stroke or hypertension. These individuals may exhibit impaired cognition, fatigue, dizziness, headaches. These things can be attributed to a number of other things. So again, we want to identify what the primary disease state is and treat it versus trying to treat a bunch of symptoms, which may lead us down the wrong path. Now going to slide 10, hepatic dysfunction is a concern. One of the things that we see would be an encephalopathy, and that encephalopathy may show impaired cognition and a number of other issues that may emerge. For example, ammonia builds up, and that can lead to encephalopathy. So again, simple monitoring and determining liver function test, and then getting a good background on the patient, good medical history, we can determine what the primary versus the secondary disease potentially is. Renal dysfunction, as I mentioned before, can have profound effects on drugs. Renal dysfunction can result in a lot of serious pathology. So what we want to do is, again, determine what the main cause is, and in all of these cases we may have to adjust drug dosages even if we identify approaching or treating the main disease state. Endocrine disorders, we've seen mood disorders associated with them, impaired cognition, and these can also be symptoms of psychological issues. It can also be a direct primary symptom of an endocrine disorder. On slide 11, think about what is happening during these states. For example, if we have cardiovascular comorbidities, we are looking at poor perfusion of the brain. We're going to get poor perfusion of the liver, poor perfusion of the kidneys. All of these things can affect both symptoms that are being expressed, as well as, especially with the liver and the kidneys, the ability of a person to handle those, to handle specific drugs that may be metabolized by the liver or excreted by the kidneys. If the liver is exhibiting any dysfunctional state, we always have to be aware of the potential for accumulation of just your metabolic waste products or metabolites of normal physiological waste that are generated. We have to be aware that drug metabolism may be impaired or altered. Blood proteins, since the liver makes these, they may be altered, and if we're dealing with drugs that are highly protein bound, that could be a real concern. And we also may be dealing with a person that may be exhibiting malnutrition, and that malnutrition may be due to the lack of conversion of nutrients to specific building blocks that our body needs. If we go to slide 12, again, I point out the problems with renal dysfunction. It can interfere with the metabolism of the excretion of metabolites and different waste products. These can accumulate. Another thing, let's not overlook that if the kidneys are not functioning properly, we may get electrolyte imbalances, which can affect the electrical properties of in the brain. We can get fluid accumulation that may occur. All of those can be associated with renal dysfunction. And then in an endocrine dysfunction, we can see electrolyte imbalances. We may also see just an alteration of anabolic functions of the body being able to repair itself and to grow and to thrive. Now, on slide 13, What we have to realize is that comorbid conditions, which we're going to see in a lot of patients, will often dictate the therapeutic choices. What I mean by that is that it will often determine which drug you're going to use and which dosage you're going to use. Generally, we're going to try to use as low a dosage as possible, and we would like to keep the person on as few drugs as possible and for as short a time as possible. Now, many of the patients that you're going to see are going to be on therapy for a long time, and so that makes it more important to monitor that patient. And as I've just said a few moments ago, the second bullet point here, we always have to evaluate whether a person is experiencing a side effect or is it simply that their disease is progressing and showing more symptoms. Anytime that you have comorbid pathology, that's going to dictate a much closer monitoring of the patient. And we have to keep in mind that sometimes age effects can show up independently or they can show up in association with the disease. So, for example, we do see that individuals, as you get older, are more likely to be sensitive to temperature extremes. We see specifically a number of drugs that you're going to prescribe are going to have the potential for producing postural hypotension. When you get old, basically your body's reflexes are moving at a much slower rate. And so one of the things that we have to always be aware of is that older patients are more susceptible to postural hypotension. That's specifically important because their chances of injuring themselves by falling secondary to postural hypotension is increased. Naturally, as we age, our renal function decreases, and probably one of the major reasons that we adjust dosages in drugs in older people deals with the decreased renal function that we experience as a natural progression of aging. We also have liver function tends to decrease, and there have been some studies which suggest that that even certain receptors, their function is altered as we get older. Now, I've mentioned monitoring, and on slide 15, in an ideal world, we would like to have a baseline before we start anybody on a drug. Many times that doesn't occur, but then we have to look at how often do we monitor throughout therapy. And obviously, the more problematic the drug is as far as side effects and as well as the number of comorbid conditions and other drugs that may be on board will increase the need for monitoring. Generally, what's recommended is we like to get a CBC, a complete blood count. That gives us an assessment of their hematological system, some baseline levels on hepatic function, renal function, and then if there is, for example, specific tests that may be dependent on the disease or therapy we're using. Some drugs, as you know, may require specific monitoring. In other instances, for example, if you were looking at thyroid function, or you had someone that had a hyper or hypothyroid, then you would obviously want to monitor thyroid function in those particular patients. Now, a couple of cases just are illustrative cases of where we can get into problems, and some of these drugs you'll use and some of them you may not use. This is on slide 16. For example, in the elderly, digoxin is a drug that is used for treating arrhythmias and congestive heart failure. One of the things that we know is that as you get older, you decrease your renal function, and digoxin is excreted through the kidneys, and so elderly patients may be more susceptible to the issue with regard to basically being more susceptible to toxicity. So we would have to be very careful of using digoxin in elderly. We would monitor renal function, even digoxin levels, if we chose to use digoxin in an elderly patient at all. In some instances, we would choose to use another drug therapy. I've seen a case of Depakote producing hyperammonemia in a premature infant. Because the Depakote is protein bound in a premature infant, what we saw was there was not a lot of protein because the liver had not developed, and the individual developed hyperammonemia. Alcoholics, very difficult patient population to treat. In some cases, they may have prolonged drug action. In other cases, they may not be able to metabolize the drugs at all, depending on how much damage has been done to the liver. Tricyclic antidepressants, we always have to be careful about using those in heart patients. The anticholinergic actions of these drugs can be potentially bothersome in patients that are that have existing heart disease. And then we have what is called like increased sensitivity to certain drugs, like I've used the hot tub syndrome. This is where that individuals that are drinking a lot of alcohol, the alcohol vasodilates the blood vessels, and then if they're in a hot tub or in hot weather, what can happen is the temperature causes vasodilation of the blood vessels, and blood pressure drops because the blood vessels in the skin dilate to try to as a result of the alcohol and the hot temperature. And so here we may have an extreme form of postural hypotension that occurs. So these are some examples of where we have to think about modifying therapy or being aware of things that can create problems. So slide 17 is sort of a summary that I want you to think about as you are studying for the PEP. Is basically we're going to need to know what is happening pathologically, because that is how we're going to generally attack the disease state pharmacologically. We also need to know the basic pathology of the patient's disease state. That will help us. We need to understand the interaction of the therapeutic agents with the pathological state. That also is going to be an issue that's got to come into play there too. So these are all things that are very important for us to be aware of, simply from a standpoint of choosing the right drug and predicting the effects that we're going to see.